we can begin.
Okay, perfect. So do you make an introduction, or you just?
Yeah, I'll make a small introduction, and I'll present you as the head of the department of the Chirec Hospitals and professor of intensive care, and then you can just go on.
Okay.
Cuando me digas, Víctor, podemos empezar. ¿Ya? Listo. So it is my great pleasure and honor to present my personal friend and mentor, Professor Daniel de Baquer. Professor de Baquer is head of the Department of Intensive Care at the Chirec Hospitals in Belgium. He's also professor of intensive care at the University of Libre de Bruxelles, and a past president of the European Society of Intensive Care. I think a professor needs no introduction. He's worldwide renowned in hemodynamic monitoring, and we'll hear from him on the subject of heart-lung interactions and cardiac dysfunction in COVID-19 patients. Thank you, Professor, for being with us today.
Okay, so good afternoon. It's my pleasure indeed to be with you, at least remotely, with this webinar. So the topic is indeed expanded and adapted from the webinar I conducted a few days ago for the ESICM. So for those who attended, there will be some replication of some aspects. The principle of heart-lung interactions are very important to remember, because indeed with COVID-19 patients, we will see patients with a severe respiratory dysfunction, but also some patients with severe cardiac dysfunction. And the combination of two aspects is really something very specific and important to realize. So remember that the heart is in the chest, and so it will be submitted to the pressure applied to the chest and then to the pericardium. So the changes in pleural pressure are transmitted to the pericardium, and hence will affect both the left ventricle and the right ventricle. One may expect these issues to occur mostly in RDS patients, because these patients are ventilated with the highest intrathoracic pressures. However, the transmission of alveolar to pleural pressure is not so straightforward. And indeed, if we look at the relationship with the pressure in the alveoli on one hand and the pleural pressure on the other hand, we have in normal condition a relative important transmission from the alveolar pressure to the pleural pressure. Roughly 30% of the pressure is transmitted. If we have a patient with RDS, due to the decreased compliance, only some part of this pressure will be transmitted to the pleura. So basically, even though we apply higher pressures, these are less transmitted in RDS patients than in normal conditions. So the transmission is decreased in low compliance states. However, we have to also remember some aspects, that collapsed areas do not transmit pressures. So in the usual RDS patients, we do not often have a huge transmission of pressure. The cardiovascular effects are often more prominent in COPD patients and or in asthma patients who are ventilated with normal or high volumes. However, we have to think at what occurs in COVID-19 related RDS. How much is it transmitted there? And it probably needs to be think in terms of the specificities of this, and especially we have really two different phenotypes. And initially, at least, we have near normal compliance, even though we have a decrease in PO2 due to the elevated shunt fraction, which sometimes culminates at 50%. So the transmission of PEEP to pleural pressure may be really higher in these conditions than in classical RDS patients. In the second step, when it is indeed impaired compliance, then of course this patient may have a lower transmission, but initially at least there may be really a high transmission of a pleural to the pleural pressure. But we do not have really enough data, and so I hope that in future we will see some publications on what occurs on the pleural pressure in these patients. Because if we look at the data on how we ventilate these patients, we can see here on the left side that the PF ratio is really very low, usually 125 as a median value here. And if we see the PEEP that is applied to these patients, it's usually the median PEEP is 14 to 15. So quite a significantly high PEEP applied in these patients. So what will be the hemodynamic impact is really something we need to think at and to look at. So thinking at the principle of heart-lung interactions, so we have with ventilation, cyclic changes to the intrathoracic pressure, and these changes affect both the left ventricle and right ventricle preload and afterload. So the first aspect is, of course, the increase in the right ventricle afterload. And this is especially due to the fact that we have alveolar vessel and extra-alveolar vessels. And when we will inflate the lungs, we will have some increase in the lung volume that will be stretching the alveolar vessels, but also will distend the extra-alveolar vessels. So the resistance of the alveolar vessels will increase, while the resistance of the extra-alveolar vessel will decrease. So the impact of the PVR is an increase in the resistance in the alveolar vessels, a decrease in the extra-alveolar vessels, and then there is the total vascular resistance. There is a U-curve. And when we ventilate our patients, we ventilate our patient from the functional residual capacity to some tidal volume here. So we will increase the resistance during the inspiration, and then, of course, increase the afterload of the right ventricle in these conditions. There is also a decrease in right ventricle preload. And indeed, though these two factors will decrease the right ventricle stroke volume. And this is nicely illustrated in this echographic study by Antoine Verbaron, where there is indeed a decrease here in the stroke volume during inspiration. And this is due to a decrease in the right ventricle preload because the end diastolic volume decreases, but also an increase in the right ventricle afterload. As you can see, the increase in the end systolic area in these conditions. So what are the effects on the left ventricle? Interestingly enough, there is an increase in the left ventricle preload, initially at least. Why? Because there is indeed some blood contained in the pulmonary vascular bed that is squeezed by ventilation and expelled to the left ventricle, increasing the preload of the left ventricle. And it is interesting to realize that the changes in pulmonary blood volume are initially a decrease because of squeezing during inspiration and an increase during, of course, a replenishment during the expiration. And so looking at the cardiac output, there is a decrease in the right ventricle output initially, while there could be in some conditions an increase in the left ventricle cardiac output. For the left ventricle, there is also a decrease in the left ventricle afterload during inspiration. Indeed, to generate the same blood pressure in the brain or the kidney, when there is zero pressure in the pleura, the heart needs to generate exactly the same pressure. However, when there is some increase in pressure in the thorax, the heart needs to generate a lower pressure so that the transmural pressure will be decreased in these conditions. So these effects here can indeed increase left ventricular stroke volume, especially when the heart is preload dependent in these conditions. During expiration, there is a decrease in the left ventricular preload due to the transmission to the left ventricle of the decreased right ventricular stroke volume after a few cardiac beats. And so this is nicely illustrated from this data from 60s, where you can see the vena cava flow here that decrease just after the inspiration and increase during expiration. When we look at the pulmonary artery flow, initially there is it is maintained for 1 beat, but then after 2 beats, there is a decrease in pulmonary artery flow. If you look at the aortic flow, it is initially increased, but then after 3 to 4 beats, there is a decrease in the aortic flow also. So we see the time difference between what occurs on the right side and the left side here in this very nice example. What is the impact of mechanical ventilation on the right ventricle and the development of acute cor pulmonale? So there are several mechanisms that can increase pulmonary artery pressure in patients with RDS. There is a decreased vascular bed with microemboli, and we have heard it occurs quite a lot in patients with COVID-19 in these conditions. There might be a reduced lung volume, but maybe this is less prominent in COVID-19 patients. There is a huge increase in mediators, and again, the inflammatory cascade is quite significantly increased in COVID-19 patients. And then there is a problem of hypoxic pulmonary vasoconstriction, and we do not know exactly to how much this occurs in COVID-19 patients, especially because these patients have high shunt fractions. So what we expect, of course, during acute cor pulmonale is that mechanical ventilation will increase the right ventricular afterload, but also decrease the left ventricular preload by dilating and compressing the left ventricle. And this is, of course, a very specific phenomenon due to the fact that we have indeed the heart in the pericardium. But so first look at the pulmonary vascular resistance. And we already have mentioned this aspect that during inspiration, we transform some zone 3 into zone 1 because of the increase in the pleural pressure and alveolar pressure. So that indeed at that time, the pressure will be higher in the alveoli than in the vessels surrounding. So the impact of inspiration and expiration. During expiration, we have indeed in many cases the pulmonary artery pressure, which is higher than pulmonary venous pressure, and which is are all higher than the alveolar pressure. During inspiration, what we have is an increase in the alveolar pressure, which becomes higher than the venous pressure. And so we transform this zone 3 into a zone 2 area. And so by this, we increase the vascular resistance in this area. So what are the consequences on the right ventricle? Well, you can see that the right ventricle is very sensitive to an increase in its afterload in opposition to the left ventricle. And so the right ventricle cannot really adapt to acute changes in afterload. And also it can dilate under abnormal conditions. This means that the ventricle will be enlarging, and this will also have some issues due to the interventricular dependence. Because if we dilate the right ventricle, then this means that we will compress the left ventricle because indeed the pericardium cannot be distended. And you can see this very nicely in this echo when you see here on the right ventricle, the right atrium, the left atrium and the left ventricle. And we can see that during each inspiration, there is bowing of the interatrial septum and also bowing of the interventricular septum from the right side to the left side. So the dilation can be evaluated by several means, and especially during echo, it is quite important to look at it. And indeed, this dilation is something very important. But it is important to realize that the global size of the heart is indeed totally preserved, but it is at the expense of a decrease in the size of the left ventricle in these conditions. Another very important aspect is the development of what they call the paradoxical septal movement. So with here, when we have an increase in the afterload of the left ventricle, we can see that the systolic time is preserved. However, when we have an increase in the right ventricular afterload, the systolic time of the right ventricle will increase. So that at the end of the systole, the pressure in the right ventricle in purple here will be higher than the pressure in the left ventricle. And by the consequence, there will be a shift from the septum from the right side to the left side. As this is illustrated here, when we see here that at the end of the systole, there is collapse of the left ventricle by the dilation of the right ventricle. Again, a very good example here in a recent COVID-19 patients, when you can see here this paradoxical septal movement in this patient. Even in addition, we have, of course, some impairment in the cardiac and left ventricular function in this patient also on top of it. So we can see here very nicely in this patient during the diastole, we can see here, we are just before the systole. Then we begin the systole, and you can see here that from compared to the diastolic here, we have indeed some contraction here, very nicely and homogeneous in these conditions. But at the end of the systole, what we will see here is suddenly what we have here is that there is a flattening here from the right ventricle that begins here indeed to be totally flat and compressing here the left ventricle. And again, in diastole, we can see again a very nice shape of the left ventricle. What could be the impact of mechanical ventilation here? The first aspect is the respiratory variations in the pulmonary artery. We can see here during expiration and during here a small one during inspiration. So there's a decrease in the stroke volume of the right ventricle. And this is very important because this means that during each inspiration, there is a very important repercussion on the right ventricle of this of the increase in the pleural pressure of these patients. And this has also been nicely demonstrated invasively in these patients, which can see here the measurement of the left ventricular pressure and measurement of right ventricular pressure. And what occurs when they apply the high PEEP in these patients, suddenly there is not only a decrease, of course, of left ventricular pressure, but we can see that at the end of the systole, the pressure in the right ventricle becomes higher than the pressure of the left ventricle, generating a paradoxical septal movement. And we know from literature in usual ADRS that the acute cor pulmonale occurs in roughly 20% of our patients. We can expect that some conditions makes the occurrence of acute cor pulmonale more likely. Pneumonia as a cause of RDS, and of course this is the case in COVID-19. Driving pressure very high, this may not be the case. Low PF ratio, this is really the case here. And high PCO2, which is also often the case when the patients are ventilated. So in many cases, we'll be here with close to 33% of acute cor pulmonale, and so routine echo is really mandated in these patients. The impact of the volume status should not be neglected, because we may think that indeed keeping this patient dry is a solution. However, we have to remember that when we have the we need to pay attention to the impact of the venous pressure. And what we have is that when we give some volume, we'll transform by the increase in venous pressure, we transform some of the zone 2 and zone 1 into zone 2 or zone 3 areas. And so the pulmonary vascular pressure resistance, will decrease in these conditions because the increase in the venous pressure. And this is indeed nicely illustrated is this data from the group of Jean-Luc Teboul, where they showed that by applying PEEP, they increase pulmonary vascular resistance. But by applying also the passive leg raising, they increase the intrathoracic blood volume, and then they decrease also the vascular resistance, the pulmonary vascular resistance in these patients. So mechanical ventilation and ventilatory conditions have major impact on right ventricular function and cardiac output. And this indeed in patients with COVID-19 can be really something very important. Another very important aspect in COVID-19 is the issue of myocardial depression and really myocarditis. And so as in many other sepsis, due to the cytokine storm, we may expect, of course, some myocardial depression. But in addition to the cytokine storm, we have also some very specific aspect in COVID-19, which is indeed the microangiopathy. And this is illustrated by the very high D dimers that these patients have, suggesting that the vasculopathy is really very important. You can even see at CT scan some small dilation in pulmonary vascular arterioles, where that pseudoaneurysms that develop in some conditions there. Also, there is some other aspect like the real myocarditis that occurs. And indeed, we have several cases of myocarditis with an MR that shows some infiltration of the heart in these conditions. And so the high troponin is also very often observed. Is it just myocarditis? Is it myocardial infarction? Both can be observed in some of these patients. With NMR, it has been shown that indeed myocardial edema is quite often present, as you can see here in this patient. And this is really something that can impair the cardiac function. A good example here of one of the patients we have here in our unit today is a patient of 20-year-old male, very exercised in sport because indeed he's part of the national team of hockey. So he's gold Olympic medal last year and last Olympics, sorry. And indeed you can see his heart here. You can see here totally impaired here cardiac function. And even when you look at the right side is not perfect in this patient either. And when you look at the cardiac output, still preserves quite interestingly, but due to the tachycardia, because indeed this patient has a VTI only of a 15, and so a stroke volume of only 41 milliliter. But due to the tachycardia 130, this patient indeed had a normalized cardiac output in these conditions. So what is the impact of heart-lung interactions to predict fluid responsiveness? Admittedly, we do not have yet data in COVID-19 patients, and so we need to think at what is the impact of RDS, the usual RDS, on the heart-lung interactions to predict fluid responsiveness. So we can use, of course, respiratory variation in stroke volume or in vena cava size, which are the most frequent one we will use in these conditions. So what we have is that during ventilation, there is changes in pleural pressure, changes in preload, and hence changes in stroke volume that will be different in patients who are preload independent and patients who are preload dependent. And we can see here some fluctuation of the stroke volume in this patient detected by echo. We can also look at pulse pressure variations, of course, in these patients. And this is probably one of the very good indices to look at the, or to detect the fluid responsiveness in these patients, as suggested by several meta-analyses and even Bayesian views that indeed shows that the probability is very good to respond to fluid when there is a significant pulse pressure, while there is a prediction to respond to fluid is very low when the patient do not have pulse pressure variation in these conditions. But the limitation is, of course, the low tidal volume. And we demonstrated this several years ago, that with the low tidal volume in blue, unfortunately, we cannot really look at the changes in pulse pressure to predict the changes in cardiac output. The high respiratory rates also are something very important, and we often ventilate these patients with high respiratory rate, usually around 30 is not exceptional. And you can see that indeed several patients who are fluid responders at 15 become fluid non-responders, at least evaluated by the pulse pressure variations at 30. Of course, this patient will still respond to fluid if you give them a volume of fluid, but just looking at pulse pressure variations, you cannot identify these patients. And importantly, a ratio between heart rate and respiratory rate is very important. And when this ratio is about above 3.6, then indeed this patient can indeed be followed by the pulse pressure variations. Low driving pressure is also something that may be a problem. And remember that due to the preserved compliance, this can be a problem in COVID-19 patients. And indeed, when the driving pressure is relatively low, many fluid responses do not have pulse pressure variations. While when the driving pressure is high, these patients indeed have high pulse pressure variations. The corpus pulmonale is, of course, also a limitation. And this was nicely demonstrated a few years ago by a group in France, when they have patients here with high pulse pressure variations, but some patients responded to fluid, and these patients had a normal right ventricular function, while patients not responding to fluids had indeed a dilation of the right ventricle. So the test is very important because we can identify this patient with right ventricular dysfunction, and if we do the echo, we will of course know this. If we don't do the echo in these patients, this becomes more tricky because we can think that looking at pulse pressure variations, this patient may respond to fluid, but this will be just a reverse. You will deteriorate the condition of this patient by giving further fluids in these conditions. Could we use the tidal volume challenge as an alternative to these patients? Well, this was tested by the Jean Table group and Sheila Neeman Mayatra in Mumbai, India. And what they thought is that they could apply a transient increase in tidal volume from 6 to 8 to unmask respiratory variations in stroke volume in these patients. And indeed, if we look at the ROC curves, we can see that here the change from 6 to 8 was indeed very nicely showing, identifying the patient who will be fluid responders. Looking at different thresholds, they can indeed identify that changes in pulse pressure variation from 6 to 8, above 50% were indeed identifying patients who will respond to fluids. So this seems to be very good. The problem still is that by increasing markedly the tidal volume, we can transform some non-responders into some responders. And so this is the problem, that we carry a risk of false positive in non-responders. And also in acute or chronic corpus pulmonale, we will also increase the pulse pressure variations by increasing the tidal volume. So this test is a little bit tricky because it doesn't help really in patients with RDS unless we have at least done some echo to rule out acute corpus pulmonale in these conditions. Could the exploratory test be an alternative? Probably yes and not. I mean, yes, it is a very good test to try to detect a patient who will be fluid responders. The problem is that it will also be affected by acute corpus pulmonale, because indeed putting an expiratory repose offloads the right ventricle, and in this condition, of course, there will be an increase in stroke volume. But this will not be really reflecting the preload responsiveness, but rather the afterload responsiveness of these patients. So it doesn't help a lot in these conditions. So still limited by the low tidal volume, and still limited also by the corpus pulmonale in these conditions. So prediction of fluid responsiveness using heart-lung interactions really remains difficult in RDS patients, and we probably need to be very, very, very cautious in these conditions. And performing echo is very important, and perhaps some other tests like the Pacific raising test can be better in these conditions than just looking at the stroke volume variation. And with this, I thank you for your attention to this webinar. Okay.
Great. Thank you again so much, Professor. This is always a pleasure to hear such an expert in these issues. And let me just start the discussion while we wait for some questions from people who are hearing us by asking you about this, let's say, phenomena that is happening where people are trying to restrict fluids from unstable patients. There is this nuance that states that COVID-19 patients should stay on the dry side of the spectrum and try to limit the amount of fluid, which I think it's a a mistake when you have hypoperfused patients and try to restrict patients from fluids. You should try to give the exact amount of fluids that patient needs and not to restrict in order to avoid multiple organ dysfunction. What are your comments on this?
Well, I think it's a very important point, and I think that fluid management is really critical in these patients. On one hand, for the lungs, we want to keep this patient dry, of course, but we need to pay attention also to other organs, and especially kidney dysfunction is really one of the major other suffering organs. And this is really something important, because in some series, 20 to 30 and even sometimes 40% of the patient develop renal dysfunction. When you have a lot of patients, it's important to try to limit the development of acute kidney injury, because you will be also limited by the number of dialysis machines you have in your unit. And so this resource can be scarce in some conditions. So pay attention to the kidney is something important, and we should not sacrifice the kidney of the patients, saying that indeed the lungs are the most important organs in this condition. So it's always a very difficult interplay between these two organs mostly. And so what we do in our unit is really, yes, we try to keep these patients dry, but we pay attention to perfusion. When these patients have adequate perfusion, which is often the case, then we can continue keeping this patient dry, ensuring that, of course, that the other organs are not suffering. When we see these other organs beginning to be suffering a little bit, then we may begin to give some more fluids to these patients. When we see also some indices of tissue hypoperfusion, we first try to improve tissue perfusion. For improving tissue perfusion, you have really two ways: fluids on one hand and the inotropic stimulation on the other hand. And so again, looking at the heart of this patient is very important. And even though initially we thought, oh, we should not do too much echo because of the safety concerns that we may have due to the viral virus, we rapidly realized that performing echo is really critical. And so we learn how to use echo in these patients safely, of course.
Yes, indeed. I think this is a very a key issue. Also, regarding the right ventricle function, a bit too much fluid could impair right ventricular function and develop into multiple organ dysfunction. So, trying to evaluate right ventricle, the right ventricle is also key. And I liked very much the slide where you measure the cardiac output of the right ventricle by putting the probe just beyond the pulmonary valve. This is a more advanced technique for right ventricle monitoring. Can you comment on this, please?
So yes, what we look at the right ventricular stroke volume with echo, and what we do is we put our probe in the parasternal view in the short axis, and then we angulate just as we do initially, just to measure the ejection fraction, and then we angulate the probe upwards to really look at the vessels of the base. And then in these conditions, we can indeed very rapidly identify the pulmonary artery. First, it's interesting in this patient to be sure that there is no clot in the pulmonary artery, of course. And second, we can also measure the flow in the pulmonary artery. And there are several informations there. The first one is just the presence or not of pulmonary hypertension. And so when we have pulmonary hypertension, the acceleration time will be decreased. The second aspect is the morphology of the flow. Normally, it is a very nice flow like in the aortic flow, but sometimes we have a biphasic flow, and this is really a sign that there is a huge impairment in the heart-lung interactions, meaning that the ventricular arterial coupling is impaired, and also having this fluctuation in the pulmonary artery trace, as we had shown in our patient before, is also something very important, because in these conditions, we can indeed demonstrate that these patients have impaired ventricular arterial coupling, meaning that during each inspiration, there is some impairment in the right ventricular output in these patients. Don't find it easily. I will try to show it again there. Yes. You can see during inspiration, the decrease in the stroke volume of the right ventricle here.
What about, Professor, other indices of right ventricular function? How about TAPSE, and what about S prime wave? Do you think this help?
Well, less perhaps than in other conditions. Usually, in many of these patients with COVID-19, the TAPSE was preserved in these patients, even though they're due to the pulmonary hypertension, which is perhaps more important than really the impairment function itself. The pulmonary arterial pressure was increased. So most of the right ventricular impairment we saw in these patients was mostly due to the increase in right ventricular afterload more than in impairment in the contractile function. When we see an impaired in TAPSE, it is more a secondary step when the ventricle is suffering even more, and that at that stage it decompensates by decreasing its function. However, in patients with predominant myocarditis, in these patients, it is very important to look at the right ventricle, because then you can see sometimes either the S prime or the TAPSE being impaired, despite the fact that these patients do not have significant pulmonary hypertension. So the situation is really complex. You have some patients with predominant lung dysfunction, and in these patients, it will be the afterload, which is the main culprit, while in some other patients, it is mostly the contractility of the left and right heart, which is impaired. And then, of course, looking at these indices is really crucial.
Indeed. And another point that I wish to comment with you, Professor, is the PEEP settings on patient on mechanical ventilation. Although when the patient is already in respiratory failure, this patient is very critically ill and very severe, and PEEP titration could be tricky. Do you wish to comment on how you set your PEEP parameters in these patients?
Well, it's not that easy indeed. So in many patients, what we do is a kind of PEEP trial, meaning that we don't just look at the FiO2 and give a PEEP according to a table or something like this. What we do usually is to try to begin with 8 or 10 of PEEP, and then increase it slowly, but also looking at the hemodynamics at the same time, not just looking at the PEEP, and looking at how the heart is reacting to the changes in the PEEP, and not only looking at the saturation of the blood. And it is quite common that we have to find the optimization of the PEEP somewhere between 10 and 14 or 16 in many of these patients. Usually when we try to go higher, we really have huge impact on the right ventricle, and the right ventricle doesn't like it, and the hemodynamics is worsening in these conditions. What we do a lot in these patients is also to put these patients on prone position, because prone position can improve a lot these patients by several ways. It's already known, of course, that prone position improves the right ventricle in usual RDS, but these patients in COVID-19 respond really very, very well to prone position, and it's not exceptional that you can decrease the PEEP also by just proning these patients. And so we have performed a lot of proning in our patients, and often we go not for 3, 5 sessions as usual, but we go for 10 to 15 or even sometimes longer sessions of prone in these patients, because these patients continue to respond to prone for a very long period of time. And even though we use ECMO quite a lot, we are limited in the number of ECMOs, and of course these patients are very young also, so we have to select the patient who can benefit from ECMO, and we push a lot prone, and we have a lot of success with a a long period of prone for a long period of time. And so most of these patients spend most of their time on prone position more than on supine position.
This is a very interesting topic, Professor, especially on the hemodynamic monitoring of patients on prone positions. And I know you remember that we discussed this on our eco course here in Bogota many times. How do you monitor using eco patients on prone position? Do you use TEE? Do you unprone the patients? Do you use other methods to monitor these patients?
Well, the TE we use a little bit less in this patient with COVID-19 due to the safety concerns, because of course you know that the digestive tract is containing the virus quite significantly. So we do not like to do so many TEs that we do usually in our other RDS patients. So what we do is more transthoracic echo in these patients. And even though these patients are prone, it's not uncommon that you can have some views of the heart even when the patient is on prone position. Of course, the usual views are not so easy, but you can still have some geometrical assessment of the heart in many of these patients.
Well, we have some questions here from the United States and some other countries. Could you comment, please, on the use of pulmonary vasodilators like epoprostenol early when right ventricular dysfunction identified, and not just used during refractory hypoxemia?
Well, we refrained from using inhaled substances in many of our patients just to prevent connection and deconnections of the ventilator. So I cannot comment on personal views on this. I know that some people have tried inhaled nitric oxide and inhaled epoprostenol in some of these patients. What I've heard from these people is that usually the response was not as good as expected, but this is just from discussion with colleagues and not personal use of it, because we prefer not to use aerosolized procedures in these patients.
What about the use of Swan-Ganz catheter, Professor? Do you use Swan-Ganz on this patient?
Well, basically, we try not to use Swan-Ganz catheters because of the high risk of pulmonary clotting. And so we try not to put these kind of catheters. We use a lot of the transpulmonary thermodilutions, so the PICO or EV1000, that give us most of the information except the pulmonary artery pressure, but because we do a lot of echo, we have some non-invasive measurement of the pulmonary artery pressure. The risk of clotting in the pulmonary artery is something we should not neglect. Remember that pulmonary embolism have been really described as elevated in patients with COVID-19. And a very recent paper in circulation is quite interesting. It's a paper from people in Lille in France, and they look at the incidence of a pulmonary artery embolism in these patients using CT scan. And what they at is that there is a higher rate of a pulmonary embolism in these patients compared to usual flu or to the usual patients with respiratory problems before. But importantly, what was the difference compared to before is that the incidence of peripheral vein thrombosis, DVT, was not so high. It was less than 5 to 10% of the patient with pulmonary embolism compared to usual 50% or something like this. So maybe, and this is my view on this patient, on this paper, is that there could be local clotting and not only peripheral embolism. And so I don't like so much having external bodies in this pulmonary artery due to these conditions. But that's just personal, because usually I like to use pulmonary artery catheter.
Yes, I know, and we've read your papers on the alternatives on the Swan-Ganz catheter, and the idea is to try to put the right catheter on the right patient, and to maximize the information and that you get from all of these devices. Lastly, I would like to thank you, Professor, for participating on this webinar. It's been a real pleasure to hear such an expert on hemodynamic monitoring lecturing us on these very important topics. And I hope to see you soon here in Bogota.
Well, it may be my pleasure, but I don't know exactly when we'll be able to travel again.
Not so soon, I guess.
Yes.
Not so soon, I guess, but hopefully someday
Yes.
we'll be able to redo our eco course.
For sure.
Thank you very much, Professor, for accompanying us. And please keep safe.
Bye-bye. Keep safe.
Bye-bye.